welcome to this channel. Today we are going to discuss epidemiology in public health, the basics and principles. If you have ever wondered why some diseases spread faster than others, or why certain health problems are more common in one area versus another, epidemiology in brief is like the detective work of public health, where you uncover the who, the what, the when, where, and why of certain health events in order to protect communities. Starting with what is epidemiology. Of course, epidemiology is a study of distribution and determinants of health-related states or events in specified populations and the application of this study to control of health problems. We can break down this definition using a classic example of the London cholera outbreak in 1854. So Dr. John Snow, often called the father of modern epidemiology, mapped out cholera cases throughout London and discovered they were clustered around a specific water pump in Broad Street. So by simply removing the pump handle at Broad Street, he was able to stop the outbreak. So this wasn't about treating sick individuals, but understanding the distribution. Here in the case it was Broad Street and the determinants, which was contaminated water, in order to control a health problem in a specified population. So that's what epidemiology is all about. We also apply what we have studied in various fields to control health problems. Starting with a brief history, from ancient observations to modern science, epidemiology, there is a rich history. If we think of Imhotep 3000 BC, who believed and taught that there is a certain spirit that can enter through the nose or the mouth or the ears that is responsible for causing illnesses, especially those unknown illnesses or strange illnesses. Some good years later, like 2500 years later, epidemiological understanding changed. And here we have Hippocrates in 500 BC. He's also believed to be the father of medicine because he came up with a revolutionary idea of that time. He linked diseases to environmental factors. So he believed that there are certain environments, whether the air we breathe, the water we drink, where we live, that determine our health. So all these, they are explanations for distribution and determinants of health. Further on, 1600 AD, having John Grant, who is believed to be the first demographer, the first man who sat down to make a study on populations, their composition, the mortality rates, fertility, birth rates, and that's why he's considered to be the first demographer. You can talk of John Snow, whom we have already talked about, 1850 AD, far, that is 1800 to 1880, lived in the same time with John Snow, and is the one who had the opposing idea. John Snow related the cholera outbreak to the contaminated water, but far related it to elevation, that those who are in lower places are at a high risk of the cholera more than those on highlands, so related it to elevation. But William Farr is also considered to be one of the founders of medical statistics. Another classic example, that is now after some good time in 1950, we have Richard Dole and Bradford Hill, who are renowned for showing the relationship between smoking and lung cancer. They also come up with a Bradford Hill criteria for determining causation. So that is a brief history of epidemiology throughout history. It has a rich history showing how it has gone on evolving. When we talk about health-related events, we are not talking about specifically infectious diseases. For example, you may start from the classic COVID-19 pandemic, that was an infectious disease. You may look at the rising rates of diabetes, that is an uncommunicable disease. Or in another case, you may be understanding why road traffic injuries are higher in maybe in certain age groups, in a certain gender. So epidemiology is wide, it is not restricted to infectious diseases, maybe environmental exposures, maybe like pollution, ionizing radiations. That's what health related events mean. Epidemiology is classified into two: descriptive epidemiology and analytic epidemiology. In the descriptive, it explains the how, because in epidemiology there are two questions: how and why. How is disease distributed? Then why? What are the determinants? So in the how, you may look at incidence, you may look at prevalence of disease, the attack rate, the mortality rates. Like you're looking at how is the disease distributed, or you are describing the condition of the population. So those are the studies you use. Or you may describe certain studies according to persons, according to place, the prevalence of disease in a certain area and another. There you are doing descriptive epidemiology. But analytic epidemiology, we are looking at why. And usually here we are relating association and causation, as we will see later. Like why is this more prevalent in this area? Why is this like this? So we carry out studies to show relationships, and these include cohort studies, case control studies, cross-sectional studies. So we are looking at the reasons or the determinants in analytic epidemiology. So we'll go one by one, looking at the basics. In public health, surveillance refers to the ongoing, meaning it is continuous, systematic collection, analysis, and interpretation of health data. Why is it done? It is essential to planning, implementation, and evaluation of public health practice. If you think of our public health surveillance as maybe a constant radar of a country's health system, just like air traffic controllers monitor planes to ensure safety, public health officials, they continuously monitor health data. So they have to collect data maybe in hospitals, they report it continuously or regularly. So in this case, it is easier to tackle outbreaks and so on. So they may report flu cases by clinics, or how many pneumonia cases have been admitted. Like this information is used to detect unusual patterns. So it has to be continuous and systematic, not a one-time event. That is why it is called public health surveillance. Its aim is to track occurrence of diseases, injuries when they have just happened, and this enables timely action, meaning the people in charge, they make responses timely. Then this information, after it has been collected, it has to be disseminated to those responsible. And lastly, it can be passive or active. You can do passive health surveillance using existing reports that have already been made, or active, whereby a certain team is sent out in the community and they receive that data right away. That is active public health surveillance. Passive, you are using reports. Active, you carry out the data collection there and then. So in this public health surveillance, you imagine maybe the recent Ebola outbreaks in Uganda. The public health teams didn't just wait for reports, but they were actively seeking out potential cases, tracking contacts, or analyzing data continuously. So there you are carrying out active public health surveillance. Even something as common as tracking measles vaccination is part of surveillance. So that is public health surveillance. When you talk of incidence, all these are measures. Here we are measuring measuring disease burden, or we are measuring how the disease is distributed. We are mainly answering the how question, that is descriptive epidemiology. So incidence is the number of new cases of a disease that occur in a specified population during a given time. The emphasis is added on new cases. So incidence is all about new cases. You think of it like maybe a speeding car entering a highway. If we say the incidence of flu in Kampala last week was 500 new cases per 100k, it means that 500 out of every 100k previously healthy people developed the flu for the first time. So they have to be new cases. We are measuring occurrence of new disease, not existing cases. So in calculation of incidence, existing cases have to be ignored. This incidence many times is used as a measure of risk, because if there is a high incidence, meaning there is a high probability that the healthy individuals will also become sick. The risk is a probability, and the incidence is a measure of risk. That is why many times risk is measured where incidence can be measured. There are mainly two types of incidence: cumulative incidence, which is also called point incidence. In this case, you go in a certain time period, that at this date, how many new cases have been recorded from this date to this date, then divide by the number of people at risk. What is important in incidence, the people who are already sick are no longer at risk, meaning we don't use the total population. Population at risk are those who are exposed, or who are at the risk of getting that disease. Meaning, during measure of incidence, in the denominator, people who are already sick are not included. Number two, you don't include people who have died because of, if you are measuring, that is why usually when you're measuring incidence, you have to determine the current population, not using the population of Uganda in 2000. The people who are already in 2000, not all of them are available at this moment, so not all of them are at risk. But if you are looking at, that is cumulative incidence, another measure is incident rate, or the incidence density. In this case, what changes is the denominator, that is total person time at risk. So the reality is that during the follow-up or the cohort, if you are following up a certain population to see how many will develop the disease, all these people will not be followed up for the same time. For example, those who will fall sick, after falling sick, the cohort may end. Some may migrate from that population, others may drop out of the cohort. So there, if you are put into consideration the matter of time, we measure the total person time at risk. That is how much you get the product of the number of people times the time they were followed. And that is what you use as the denominator. So that is why it is also called incidence density. So all these measures are appropriate in different cases. And lastly, in incidence, we are looking at how fast new cases are occurring. So it is, and sometimes the measure of incidence will be the same as attack rate, as we will see, later. So if this is the example of the table, if we are to measure incidence, we are looking at the probability that the people in that population will get the disease. So if I look at the exposed, from, for example, in this table, if I look at the table of the exposed, the incidence, I will get those with the disease divided by the total number of people who are exposed. So that will be A out of A plus B. In that case, I have measured the incidence rate, the incidence among the exposed. If I'm measuring the incidence among those who are not exposed, I'll get those who have the disease divided by the total. Remember, it is like a probability or a proportion. The probability that people in that category will get the disease. So you get those with the disease divided by those who were exposed or the population at risk. That is the measure of incidence. When you go to prevalence, we are looking at total number of cases. That is both old and new cases expressed as a proportion that exists in a population at a given period of time over a specific period. So if incidence is about new cases, for example, if you look at this example of this highway, if the incidence we are looking at the new cars entering the highway, we will only count the new cars divided by the total number of cars which were in the highway. But in the prevalence, we will count all cars on the highway. That is that is a simple illustration that we are looking at both old and new cases in prevalence. So if prevalence tells us how widespread a disease is in a population, and it also expresses the burden of disease, how many people have the disease in a population, how many cases are present. It also has two types of measurement. Point prevalence, we are looking at a specific time. On a specific day, you go and count how many people have the disease. That is point prevalence. Period prevalence, we are looking at a certain period. You count all cases that were recorded during that time. Whether someone got it and they recovered, whether they got it and they later died. Like prevalence, we are looking at the total cases that existed at any time during that period. So if I'm looking at annual prevalence, I'll go and I collect records of all cases that were recorded during that year. That is annual prevalence. Month prevalence, all cases that were recorded during that month. So that is basically about prevalence. When we talk of the attack rate, I would say the attack rate is similar to incidence, but usually the term attack rate is used in cases of epidemics or an outbreak. You are looking at what is the proportion of people who have become ill after the exposure. There is this image behind in the background. How many people were attacked by a disease after a specific exposure? So imagine a family gathering where everyone ate the same potluck dish or they ate from the same plate. If 10 out of 15 people who ate the chicken salad developed food poisoning, then the attack rate is 10 out of 15. So in this case, if the outbreak broke out after a meal, people started vomiting or what, I will only look at the people who were exposed, how many people ate, then how many have developed the disease so far. You're getting it. So we are looking at the attack rate of the disease. How fast is the disease spreading or how fast is it manifesting? So attack rate and incidence are similar. It's just that attack rate is used mainly in outbreaks. So the formula is almost the same for incidence. Number of new cases among the exposed divided by number of exposed individuals. So those who were not exposed, probably those who were not around on the party who didn't eat on that dish will not be included in the attack rate. Commonly used in foodborne outbreaks, epidemics, and acute exposures. It helps us to identify the source of outbreaks. So you may measure attack rate among those who ate chicken salad, then you measure attack rate maybe among those who did not eat, or attack rate among those who drank this and those who drank that. You are trying to establish what was the cause or the source of the outbreak. Where there is a high attack rate, it means most likely the cause is present. We have mortality rates. All of these, remember, these are terms used in descriptive epidemiology. You are describing the distribution of a disease, the burden of a disease. There is no specific analysis. It is more of collecting data and presenting it or describing it qualitatively. That is descriptive epidemiology. Mortality. Mortality rate is the rate at which deaths occur. Of course, mortality is about death. It tells us how many people are dying in a population in a certain period. So if a country has, for example, a crude mortality rate of 8 per 1,000 people, it means 8 people die for every 1,000 per year per 1,000 people. Meaning for every 1,000 people, 8 people will die in a year. That is like a crude mortality rate. So it is a broad measure of the overall health status of a population. It shows you the health status of the population. If the mortality rates are high, the health status is poor. So its measurement is simple. You get the number of deaths, divide by the total population at risk during that period. Then what you multiply with depends on the size of the population, either per 1,000, per 100,000. Or in simple terms, mortality rate is the frequency of deaths in a defined population. It is usually expressed annually, that is per 1,000 per year. The types of mortality rate may be crude mortality rate. In crude mortality rate, you count all deaths irrespective of the cause. So I will go in a certain village, I say how many deaths have been recorded, divide by the total population in that village. Then I say the crude mortality rate in this village per year is this. Or you may decide to categorize it as cause-specific mortality rate. How many people died because of diabetes out of the population at risk? How many people died among those maybe in the adults? That is age-specific mortality rate. So overall, also mortality rate reflects the burden of disease. For example, this table has tried to classify the cause mortality rates, that in hypertension, how many died among the blacks, among the whites, among the males, among the females. So you're relating gender, you're relating the cause, you're relating to sex, you're relating to the race. So mortality rates can still be broken down according to cause. It may be cause specific or age specific or gender specific. But basically, mortality rate are the total number of deaths, the frequency of deaths in a population. Case fatality rate, as the term suggests, the proportion of individuals or how many individuals among those who were diagnosed with a disease have died from it. So in brief, it is like we are measuring how dangerous a certain event or disease is. It is about the deadliness of a specific disease among those who actually get it. So when you're measuring case fatality, you only include the denominator will be how many people were diagnosed and how many died because of that disease. Then you measure the proportion. So it is more of a measure of the deadliness or severity or lethality of a disease. The formula number of deaths out of number of diagnosed cases times 100. So it is expressed as a percentage, however much it is called a rate. It applies usually to acute diseases or outbreaks. For example, if you have a cholera outbreak, you want to say what is the case fatality among those who have been diagnosed with cholera, how many have died because of it, expressed as a percentage. That will be the case fatality rate. A high case fatality rate means that a disease is very deadly. Life expectancy is with the last measure we can look at in descriptive epidemiology. Life expectancy is is the average number of years an individual of a given age is expected to live if current mortality rates continue. So usually the life expectancy varies among the children, among the adolescents, among the middle aged, among the old. So life expectancy is age specific, but you are trying to determine what is the average number of years for this given age. So and it depends on the region, of course, depends on which population, and this information it depends on the current mortality rates. So we'll look at what is the mortality rate in this age. According to this mortality rate, what is the expected lifespan or life expectancy for this age? If you look at the graph in the background, you see that it has been postulated that as time goes on, the life expectancy is increasing. So life expectancy is like a snapshot of a population's overall health. It is often used as a key indicator of a country's development. Meaning, when you hear that life expectancy at birth in Uganda is 64 years, it means on average, a baby who has been born today in Uganda can expect to live 64 years. They are linking it to a certain age. That at birth it is 64 years, meaning you'll find that at a certain age, the life expectancy goes on changing. And that is assumed if the current death rates which they have used to measure it have remained constant, meaning if the mortality rates change, even the life expectancy changes. That is what life expectancy means. Then we shift to the study designs, which are mainly used in the analytical epidemiology. We are analyzing the why. Why are these appearing like this? You read information from a descriptive epidemiologist, and you want to find the background. What are the determinants? What are the causes? What are the factors associated? That is when we talk of a cohort study, case control studies, we talk of randomized controlled trials. So we are going to start with a cohort study. Cohort study is an observational study in which a group of people, observation meaning you're not doing experiments, you're simply observing, you're collecting information and analyzing it. So it is an observational study, an observational analytical study in brief. So in a cohort is a group of people. So you follow up, you get a group of people who are free from the disease. Then you follow them over time to see who develops the disease, meaning it is longitudinal and more of prospective. You get free people, meaning they don't have a clinical disease. Then you follow them up and see who will develop the disease of your interest. So you compare those who are exposed to a particular factor with those who are not. So you may get a cohort, then you follow up maybe smokers, and you see the incidence of a certain disease after time. Follow up non-smokers. So you look at a certain exposure, or you may look at multiple exposures. So you'll see the outcome after time. That is how a cohort study works. So that is an illustration. So if you may want to determine, you think of a cohort study like following a group of friends over many years to see who gets sick or who doesn't based on their habits. So they're either exposed, you follow them up, you see those who are diseased, those who are not. Then the investigator makes conclusions. So what is most characteristic about it? You are starting with a disease-free population. Then you group them according to exposure status. like we said, maybe having smokers and non-smokers. You follow up participants over time to see who develops the disease. So mainly the cohort study is used to measure incidence and calculate the relative risk, which is also called the incident rate ratio. To measure incidence, you have to follow up a case. That is why mainly incidence is measured in cohort studies. You may not talk of incidence or relative risk in a case control study where you are using where you are interviewing people to get information. But in incidence, you follow up and you make regular reports. Then you use these regular reports to calculate what was the incidence of this disease in the population. It can be prospective, that is forward looking, or retrospective. The prospective is the common, but retrospective is historical. You simply use the past records and you try to reconstruct the exposure and follow up. So you assume you're using past records to construct a cohort as if it was prospective. That is a retrospective cohort. So it enables to expose temporal relationship between exposure and disease. One of its main advantages, it can study multiple outcomes from a single exposure. Because I may be having a smoker, I'm following up in the interest of lung cancer, that I may realize later on that smokers are developing diabetes, are developing another condition. So I'm able to discover many outcomes from a single exposure, that is, if there are any. But other study designs cannot do that. It is less prone to certain biases. Here you are not getting subjective information. You are observing and making conclusions. So you don't expect things they recall bias. Because it is you are not interviewing, you don't interview the cohort participants to get information from their past, but you observe them, you study them and make conclusions. Case control. Case control, as the name suggests, we are looking at the cases and the controls. So first is an observation study in which people with a disease, who are called cases, are compared to people without the disease. Those are the controls. To determine prior exposure. So this one is usually common for rare diseases. You get those who have the disease, you try to trace their exposures. Did you do this? How long did you do it? What do you think caused it? So you're trying to look for what would have been the cause, but while interviewing those with the cases, interviewing the cases, then you also interview the controls. You look at their lifestyle. What are they doing differently from those who are having the disease? Then you try to establish the odds of the exposure. That if you are looking at the cases, what are the odds that they were exposed to a certain exposure? Meaning if I'm having people with lung cancer and those who don't have lung cancer, I ask those with lung cancer, I try to interview them. I'm trying to determine what are the odds of exposure to smoking. Then I look at the controls, those without the disease, what are the odds of exposure to smoking. So it is different from cross-sectional. In a cross-sectional, you just want to determine do you smoke or not. But case control, you want to determine a lifestyle backwards. How long have they been doing it? What are the odds of exposure? So that's why many times case control, because you cannot measure incidence, you have to use odds, because incidence cannot be measured like in cohort. This is a classic illustration. This is the onset of study. You're having those with a disease and those who are not on the right side. Then you try to establish their past by interviewing them or collecting information from them. So its main problem is recall bias. People may forget who may not be good at remembering, who may keep up some information for protective issues, all those. That is, so it is not very suitable, but it is suitable for rare cases, because in a cohort study, as you saw, cohort, you need a large sample size. You need to follow up a large sample size. But in rare diseases where you may find very few cases, cohort study cannot give you consistent results. So then cost control becomes suitable for those rare cases. Rare cases means diseases with very low prevalence. So in brief, case control starts with people who already have the disease. Those are the cases. Then you compare them with the controls. Case control is retrospective. You look backward in time to assess previous exposures. So you are having cases and controls, you are trying to assess their exposures in the past. As we said, it is best suited for rare diseases. Those are diseases with long latency. It is efficient in terms of time, cost, and sample size. Because case control, you don't need many participants. It is cheap and it is not time consuming like cohort, where you may need like 10 years. For example, the cohort of Dollar and Hill, between smoking and lung cancer, over 10 years following up cohorts to establish that. But case control is not much time consuming. Notable to note, case control, it measures the odds of exposure and it also calculates the odds ratio, and we'll talk about them later. It cannot directly calculate incidence or relative risk, because you're using recalled information. You cannot measure the probability that this population will get the disease. You can only do that after you have followed them up. So it cannot measure incidence, though there are limitations. It will only measure incidence. It will only approximate to the relative risk if the prevalence of the disease is very, very low. We talked about recall bias, selection bias. That is, upon the interviewer, you may select an uncomparable control group, because you also have to define who is a case, who is a control. So you may get a control group which is not representative. Then requires careful matching and control of confounding variables. Confounding can be a great limiting factor in case control, because you are asking people, what were you doing, how were you doing it? So you may establish a relationship, yet there was a confounding factor that was influencing it, that the interviewee failed to identify or didn't know might have contributed. Then the last one we are going to talk about among the analytical. This is an experimental study design, randomized controlled trials. Here, participants are randomly allocated to receive either the intervention being tested or a control. So first of all, you get participants, then you randomly assign them either to be among the group which is going to be treated or among the group that is going to receive a control. So they have to be randomly assigned. The random assignment is to eliminate the confounding, meaning confounding is equally distributed, since my participants have been randomly assigned. So the outcomes in the treated group and the control group, they have to be compared. This is the illustration. Probably you're going to get patients. Maybe you want to compare, you have made a new drug has been developed. Maybe you're comparing simvastatin and vitamins. So one group will be given the simvastatins and the other one given vitamins. Then you look at the incidence, or you compare these two groups You follow them up for some time, so it looks like a cohort, so you can measure incidence and risk in randomized controlled trials. Then after you compare the results, if the relative risk is high, then chances are, then meaning the drug or the intervention being tested is highly effective. These RCTs is the gold standard for evaluating efficacy of new treatments, meaning it has to be carried out. It is generally approved to be the best method. Participants must be randomly assigned. That is why it is called randomized controlled. Then it needs a control group. If you are giving this group your new drug, you need another group to give another standard drug or maybe a placebo, so that you compare the outcomes in both groups. It requires blinding to reduce bias from participants or investigators. Like you don't need to disclose to know which participants are in which group or which group is being given which drug. Even the investigators, maybe for the case of the investigators, do some blinding, so that even the investigators doing these trials, they don't know those who are belonging to which group. All these are trying to reduce bias. Then the outcomes have to be assessed objectively. It requires ethical approval, of course, because you're going to test a new treatment. Probably it has never been used anywhere, so it has to be approved. You have to get informed consent from the participants. So that is it for we have made a brief description of the descriptive epidemiology and analytic epidemiology. Another basic principle in public health is screening tests. These are different from diagnostic tests, whereby a screening test is applied to people without symptoms to detect disease early during the preclinical phase before symptoms appear. Meaning you're screening for a disease even before someone comes to the hospital to show their need for screening. But a diagnostic test, it is used to confirm or rule out a disease in someone who already shows signs or symptoms. So basically in public health, with this screening, diagnostic tests are mainly in clinical settings, but screening, it might be mass screening. You go out in the population, you test them to see those who have the disease, but probably they have not yet developed their clinical symptoms. So one of the importance of this screening is to try to tackle the disease in its clinical phase. That is the main difference. So you may be comparing a screening test and a diagnostic test. Maybe in COVID-19, we would have made a screening test. You come to people who are not ill, maybe they are not coughing, then you screen them and test for COVID. But diagnostic, meaning you are going to assure someone that they have come, they are coughing, they have flu. You want to diagnose, are these symptoms because of this? So people already have the clinical signs. The purpose, screening tests are for early detection in asymptomatic people, but diagnosis is a confirmation in symptomatic individuals. One of the limitations of these screening programs is lead time bias, that is detecting disease earlier without improving survival. Now, you detect the disease earlier, but without any interventions or any solutions to improve survival of those who have been screened. Then also overdiagnosis bias. That is, a disease may be detected which may never become clinical. So that is what they call overdiagnosis. So it may even never cause symptoms or death, but someone has been screened, they have been told you have this, you have this, may cause the unnecessary depression, yet the disease may not progress at all. Another section important in public health is assessing performance of diagnostic tests. And many times in public health, you assess the available interventions. Are they effective? So even if you're having screening tests or diagnostic tests can be carried out to see their performance. So this one involves how accurately a test identifies disease in individuals. So knowing if a test works is critical because we can't use a test that gives us wrong answers. Imagine a new rapid test for malaria. How do we know if it is actually good? Meaning you need to assess its performance based on several key measures, which we are going to dive in. There are mainly four tests, diagnostic tests or measures of performance. Performance can be measured in terms of sensitivity, in terms of specificity, the positive predictive value, the negative predictive value, the accuracy, the reliability. But mainly, these four are used to assess a test. And they are also to understand them, to understand their calculation comes from understanding what they mean. For a test to be sensitive, what is it sensitive to? Meaning it is sensitive to the causative agent. If you're having a very good sensitive test for malaria, meaning it is very good at detecting plasmodium. So mainly when you are testing the sensitivity of a test, we are measuring how many true positives we are measured as a proportion of those who have the disease. So if I come to the population where 50 people out of maybe 100 in that population really have that disease. So I'm going to use this test. If I'm assessing it, I'm going to measure how many of those who actually have the disease was this test able to capture. That is its sensitivity. It means if a test is 100% sensitive, which may not be ideal, but 100% sensitive means it will detect all of those who have the disease. If it is 90% sensitive, it means it will only detect 90 out of 100 of those who have the disease. So that is a measure of sensitivity. That is why we get the true positives that were measured by the test divided by the true positives and the false negatives. Because the false negatives and true positives, both of them have the disease. It is just that the false negatives were poorly detected by this test. When you go to specificity, a test is specific to a disease. And if a test is specific to that disease or to that, yes, to that condition, then it will be good at identifying those without that disease. A specific test is good at identifying those who don't have that disease. That is when we say that it is specific. Meaning a test which is 100% specific, it means it is able to identify all people who don't have that disease. So I'll get that the proportion, how many people of those who are healthy was this test able to detect. So I get those who are true negative, divide by that sum of the true negatives and the false positives. And if I'm adding true negatives and false positives, I'm looking at the people who are healthy. However much false positives, meaning the test might have said they are positive, yet they are negative. So that's the measure of specificity. Positive predictive value and negative predictive value are like probabilities. For example, positive predictive value, I want to measure how many true positives were measured out of all those who are tested positive. Meaning, it is like you're measuring the probability that a test will measure true positives out of the total positives. Negative predictive value, how many true negatives were measured as a proportion of all negatives. That is how is the test good at detecting negatives? That is negative predictive value. Positive predictive value, how good is the test at measuring positives? So those are the main tests for performance. As you said, sensitivity, how good is the test at correctly identifying those who have the disease, meaning it is sensitive. If it is specific, it means it has the ability to test to correctly identify all those who don't have the disease. Positive predictive value, probability that someone with a positive test truly has the disease. So I'll gauge those who are true positive, divide by the total positives that were detected by that test. Negative predictive value, I get the true negatives out of the total negatives. That's basically about those four. Then the accuracy of a test, meaning I want to measure how good is it. So I will get all the people it was able to identify, divided by the total population it measured. So I'm going to get the true positives, true negatives out of the total population. I'm measuring its accuracy. How good is it? How accurate is it? Meaning how many true people with those states were identified, whether negative or positive. Reliability, ability of a test to produce consistent results when repeated under the same conditions. So you get this test, you measure its performance, then you try it in different settings. You see if it is consistent in various settings. Then it can be considered reliable. Changing patterns of community problems. This refers to observable shifts in the types and causes and distributions of health conditions. Our health challenges are not static, they evolve. For example, 100 years ago, the biggest threats were often infectious diseases. For example, you look here at this graph, you show tuberculosis, maybe probably you say in which age, but maybe in 1950, they were mainly infectious diseases like cholera, polio. But today, in many developed nations, the leading causes of death are chronic diseases like heart disease. You're seeing cancers, the diseases which are not infectious. When you talk of diabetes, these are now the common diseases, meaning patterns of community health problems change with time. That's a reality. So there is always that dramatic changing pattern that shapes public health priorities. So we need to assess what are the factors responsible. Why is it that the problems of the community keep on changing with time? Number one, we can talk of epidemiologic transitions. For example, if a certain area which was previously not industrialized becomes industrialized, even its problems change. Um, an area which has become industrialized, you're going to talk of pollution, you're going to talk of exposures to fumes, maybe people working in these industries. Like when there are changes in the environment, common in society is moving from low to high levels of industrialization and development. There is a shift, a transition there is an epidemiologic transition. So that is why you see that long ago, probably there were infectious diseases. But now if they construct many water systems, water is being purified, if water systems are renovated, a shift shifts from infectious diseases, then we start of talking of non-communicable diseases. But also these patterns change due to emerging and re-emerging diseases. You get new health threats. For example, 2020, talk of COVID-19, it was not there before. So now these new emerging threats, they modify the pattern. Now the problem of that time was an infectious disease. But there is also re-emerging, maybe old diseases. You hear maybe tuberculosis where it has been taken to be heard of, then you hear a re-emergence of tuberculosis or Ebola or cholera. So also emerging and re-emerging diseases, they modify the patterns. Number three, lifestyle and behavior shifts. You find that people maybe who used long ago maybe working in gardens, doing doing a lot of hard stuff. Now people are seated in offices, people work well seated. There are a lot of physical inactivity, lifestyle changes, maybe a lot of alcohol, poor diet, tobacco use. These shifting in behaviors, they account for the changing patterns. Number four, environmental and occupational hazards. If we talk of urbanization, it comes with a lot of effects on health. As we look at determinants of health in a while, we talk of pollution, we talk of climate change, which may introduce new risks. And now you start talking of asthma because of environmental hazards, maybe due to pollution. You talk of vector-borne diseases. But even changing work environments, someone working in a different sector, changing occupation, occupational hazards, people working in landmines, in quarries, they are exposed to different risk factors. So there will also be a change in pattern of the health problem of that area when there are environmental occupational hazards. Demographic changes. Remember demography, you're looking at the composition structure of the population. For example, if you go in a country with a lot of old people, their problems will be different to a young generation, a country with a lot of young people, because even demography influences is a determinant of health. So maybe if long ago most people were old people living in higher like old aged people, if with the time like the population demography changes, then we start having a lot of young people, you'll see a noticeable difference in the pattern of the health problems. Where we have aged people, we are talking of dementia and stroke. In a young generation, we may be talking of other diseases. Number six, technology and medical advancements. Improved diagnostics. There are some diseases which didn't have diagnostic tools long ago. So right now they may seem they are emerging or they are increasing, yet it is due to better diagnostic tools that have been brought up, or even frequent screening or detection. If you keep on, the more if you're having diagnosis frequently, even more cases will be reported, the prevalence will be high. All these factors, they shape, they account for that changes in patterns. That is why you find long ago infectious disease is now non-communicable. It is due to those factors among others. What is health? This is a UN definition that health is a state of complete physical, mental, and social well-being, meaning it has three dimensions. Physical, that's the body; mental, the mind; and social, that is how people relate. So you see that health is considered to be a continuum, and it is not in only one dimension. If you only focus on the physical, someone who is physically well but depressed has ill health. So it is not merely absence of disease, and also adds on the ability to lead a socially and economically productive life. Meaning, however much you may be disease free, but you're living a social and economically a life which is not productive, you will also be considered to have ill health. So that's why the World Health Organization defines health as a spectrum, that it is dynamic, it is not static. You are either at one point but you are going to another. Today may have positive health, which is the highest peak, and tomorrow you may die, which is the lowest point on this spectrum. So you may be free from sickness, that is also a level of health. You may have better health or positive health. Down the spiral, you may have unrecognized sickness, meaning you look to be normal, but you are not healthy. You may get some mild sickness, severe sickness, which may lead to death. So when you're looking at health as a spectrum, you look at it as a continuum. It is not a static condition. What are the factors that determine health? Remember, we looked at epidemiology, we studied distribution and determinants of health related states or events. So it is notable to note that many factors combine together to affect the health of individuals. Many times, many determinants intersect to to determine the health of individuals. Whether people are healthy or not is much determined by their circumstances and environment. So it leads that even circumstances and environment, many times the situation of health of certain people is not by their own making, but circumstantial or related to their health. If you ask that why are some communities healthier than others, it is rarely just one thing. Or if you think of a child growing up in a deprived urban area, and you compare with a child who has grown up in a wealthy green suburb, their access to nutritious food, to safe play spaces, to quality education, to clean air, they are vastly different. So all of which are determinants of health that will shape their life trajectory. So determinants of health, we are looking at factors that influence people's health. Of course, there are many factors, but you may talk of income and social status. Studies consistently show that higher income often correlates with better health outcomes because, of course, it will allow better nutrition. You eat well, you'll have good housing, you have good health care. If you consider education, better education often leads to a better job prospects. And the more you study, even the job prospects are better. So this will affect health literacy, how much the people know about their health care. So the more people are educated, the healthier their choices. You talk of physical environment, maybe in refugee settlements, and you contrast with someone living in a city or in a well-developed home. Because you talk of access to clean water in these physical environments, you talk of green spaces or safe housing. They are all fundamental determinants of health. The social network, how many people are, the social network group someone has, their access to health services, and also the quality of health services, and also important are the genetics. There are some diseases which are more prevalent in certain races, in certain ethnicities. There are some diseases which are completely due to genetic reasons. We talk of hemophilia, sickle cell disease, all those are determinants of health. Not talking about gender, not talking about age. So many times factors intersect. You find someone poor at the same time living in a bad physical environment, At the same time, they are not educated. At the same time, they don't have access to health services. So you find many determinants of health intersecting to determine their fate. So when you look at determinants of health, automatically it sends you to the risk factors, which we call attributes, characteristics, or exposures of an individual that increase the likelihood of developing a disease or a health related event. Say it can be an attribute, it can be a characteristic or an exposure. In brief, a risk factor is anything that makes you more likely to get sick. We all know that smoking is, if you talk of tobacco use, that smoking is a major risk factor for lung cancer. But it doesn't guarantee you will get cancer, but it significantly increases your chances, meaning it is a risk factor. Another example may be a family history of heart disease. Family history of heart disease, you find that heart disease is more common in a certain family, meaning their genetics are now become a risk factor for developing that heart disease. It simply means that even their children have higher chances of developing that disease. So meaning it qualifies to be a risk factor because it is increasing the likelihood of the disease. Number one, it must precede the onset to be called a risk factor. Meaning it has to first, if you are doing a study, the exposure must come first, then the disease come next to say that this exposure is a risk factor. It has to be associated with increased risk of disease. Meaning if the risk factor is high, we expect that where that exposure is high, we expect a higher risk. That is why many times in the next calculations you are going to be doing, you are calculating the relationship between an exposure. You are comparing those who are exposed and those who are not exposed. That is in cohort studies. Risk factors can be grouped as modifiable and non-modifiable. Most modifiable risk factors are due to lifestyle, like smoking. You may choose to smoke or not. Diet, you choose what to eat. Physical inactivity. But there are those which are non-modifiable, like age, sex, genetic traits. Like if, for example, cervical cancer, it is for females, meaning being a female itself is a risk factor for cervical cancer. Having a cervix is a risk factor itself. So there are those which are not modifiable. They have their importances in understanding causation of disease, because many times when you're assessing in these analytical studies, is there a relationship between this exposure and the disease? Is the relationship causal? Is it a cause and effect relationship? How can we prevent? So all this information, if you are able to identify risk factors of a certain disease, it is easier to develop interventions to prevent it. So this one brings us to association and causation. Association and causation, all these are measures which are used in risk factors. Association is a statistical relationship between two variables such that changes in one variable correspond to changes in another variable. So association is simply finding a connection between two things. It is like seeing two friends always together. You might notice that ice cream sales and drowning incidents both increase in the summer. Like during summer, the ice cream sales increase and also the rates of drowning increase. There is a clear association. But does eating ice cream cause drowning? Of course, the answer is no. So they are both associated with a third factor. That is when we talk of confounding. You're getting? So with the increased ice cream sales, just because ice cream sales increase during summer and also drowning increases, it is not automatic that ice cream is associated with drowning. So it might be due to warm weather, which leads to more ice cream consumption and more swimming. It might be due to the hot sunshine causing both of them, hence confounding the relationship. So association, one factor changes, then also another one changes. That is when we say that they are associated. Association can be positive or negative. If it is positive, when the exposure increases, the risk of disease also increases. Like in the case of cigarette smoking and lung cancer risk, the more cigarettes you smoke, the higher the risk of lung cancer. That is positive. Negative association, exposure increases, the risk decreases. Like the more you do exercise, the lower the risk of heart disease. That is a negative association. Number three, association is not equal to causation, just like we mentioned in the early example. Just because two things are associated doesn't mean that one causes the other. Association could result because of chance, because of bias or confounding. It might be due to chance. You record results on a certain day, then you are showing that hey, there were very high rates of this and also this. It might be due to chance, it might be due to bias or confounding. Meaning, especially when you are carrying out experiments which are meant to establish association, bias, confounding, and chance have to be eliminated. In the association, we can measure association using relative risk or odds ratio. The higher the relative risk, the higher the association. In both of them, whether in case control or in cohorts, if the relative risk is if the relative risk is 1, it means there is no association. If the odds ratio is 1, meaning there is no association, meaning what you are studying is not a risk factor. So many times association, in measurements of association, we are trying to establish, is this factor a risk factor? Yeah, is this factor a risk factor? That is in brief. But causation, what you have to note that all causation, all causes are associated, but not all associations can cause that condition. A causation is a situation in which a particular exposure or factor is responsible for producing a specific health outcome. Causation is the holy grail, proving that one thing makes another to happen. For example, you know that Ebola virus causes Ebola hemorrhagic fever, meaning there is a direct established link. The virus is causing the Ebola. This is different from just an association. It means that without the virus, you won't get the disease. That is what you mean by a cause. And of course, there are types of causes, which you got in the types of causal relationships. There are 4 types. We have causes which are necessary and sufficient. And this is the clearest causal link. It says that without the factor, the disease does not occur, and the factor alone can cause the disease. To establish its necessity, it means that factor must be present for you to get that condition. Sufficient, it means that factor is able to cause the disease when it is alone. Meaning if it is both necessary and sufficient, meaning it is the only cause of that disease. And many times necessary and sufficient causes, they are for infectious diseases, that you may know that this disease, to get rabies, there must be rabies virus, meaning rabies virus is unnecessary and sufficient cause of rabies. You're getting it. Number two, we have causes which are necessary but not sufficient. Here, the factor is like a required ingredient, but you need other things too. Like it is necessary, meaning it must be present, but it is not the only ingredient. For example, you talk of, in the cases of tuberculosis, Mycobacterium tuberculosis is necessary to cause tuberculosis, but not everyone who has this bacterium will get sick. So since not everyone that contains the bacterium will get sick, it means Mycobacterium tuberculosis is not sufficient, but it is necessary. Why is it necessary? Even if not everyone with the bacterium will get sick, no, everyone who gets sick must have it. That is necessary but not sufficient. Number three is sufficient but not necessary. It means that that factor alone can cause the disease, but other factors can also cause the disease. Necessary meaning it must not be present for everyone to get the disease. But if it is present, it can cause that disease. An example is in the case of leukemia. You know that ionizing radiation, high doses of ionizing radiation can cause leukemia. But leukemia can also occur without it, meaning it is not necessary for causing leukemia. There are other causes, but if you have high doses of ionizing radiation, even if other causes are not present, it will cause that disease. Lastly, the last type of causal relationship is neither sufficient nor necessary, and this is most common in chronic diseases. If it is neither sufficient nor necessary, it means that factor contributes to the disease but does not cause it alone and is not essential for that disease to occur. Does not cause it alone and is not necessary for that disease to occur. It means that it is an ingredient. There are other ingredients, but even if it is not present, other ingredients can cause that disease. They have given an example of smoking. Smoking contributes to lung cancer, but it is neither sufficient because not all smokers get lung cancer. Meaning smoking alone is not sufficient enough to cause lung cancer. Other factors must be present, meaning it is an ingredient. It is not necessary means that it is not necessary, meaning even in its absentia, someone can get lung cancer. So since non-smokers can still get lung cancer, it means smoking is not necessary for someone to develop lung cancer. Since not all those who smoke have lung cancer, it means smoking is not sufficient. And they have said that this is most common for most chronic diseases where you talk of diabetes, you talk of hypertension, that you cannot get most of the causes of diabetes, of hypertension, they are neither necessary nor sufficient. So after talking about association and causation, when do we call an association to be causation? Meaning it has to go through the Bradford Hill criteria. The Bradford Hill criteria for causation. These ones were made by Bradford and Hill, those who established the relationship between lung cancer and smoking. Number one, in this criteria, there must be a strong association. Means if you carry out a cohort study or a case control study and the odds ratio are very low, or the relative risk, okay, it may be greater than a half, but it is It is low. Maybe greater than 1, but it is low. If if the association is low, then it does not qualify to be considered as a cause. So usually, in the calculation of relative risk, for greater relative risks which are close to 1, or for high odds ratios, then we start considering this relationship may not only be associated but also a cause. Number 2, in the criteria, it must be consistent. If you carry out that same study in different settings to find the same association, it must be consistent. Then you can say that then it is likely to be a cause. Number 3, it has to be specific. That means that whenever that exposure should be leading to a single disease outcome, not many unrelated ones. So if you get the exposed, or if you are carrying out a randomized controlled trial, but the exposure is leading to many uncoordinated outcomes, then its validity for being considered as a cause is low. Number 4, temporality. That is a temporal relationship. For it to be a cause, it must be present. The exposure must precede the outcome. That is what we talked about. That is temporality. So if you find that the outcome can happen before the exposure has happened, then it cannot be considered as a cause. Number 5, biological gradient. If we increase the exposure, does the risk increase? That is a dose response. If I increase the dose, does the risk among the treatment group, does it increase? So if there is a high biological gradient, then chances are very high this is a cause of that outcome. Number 6, plausibility. Plausibility means there must be a credible mechanism that you can associate, that you can link to your association relationship. If you are saying there is a relationship between smoking and lung cancer, are there credible mechanisms that can defend the relationship you are trying to establish? So if this relationship you are establishing, if it is conflicting with already established facts, then it is hard to be considered as a cause. Number 7, it has to be coherent. Coherent means coherent should not conflict with a known natural history or biology of that disease. So if you are considering lung cancer, there is natural history which is known, the biology of the disease. So if you are establishing a causal relationship which is totally conflicting with the biology of the disease or natural history, then it cannot be considered as its cause. Second last is experiment. Many times establishing a cause requires a lot of analysis more than establishing association, because you need evidence from interventions or trials that reducing the exposure decreases the strength of the causal inference. Lastly is analogy. In the analogy, if there is a similar exposure which is known to cause a similar disease, then it supports the plausibility of your current association. So if your exposure and the disease you are studying, there is also another established association or cause between an exposure that looks like the one you are looking at and an outcome that looks like the one you are looking at. It can also defend your plausibility. Those are the 9 criteria of Bradford Hill for establishing whether association is causal. We've been talking about risk and odds ratio. The risk, we mean the chance or probability that an event will occur in a defined population. The risk is simply your chance of something happening. We talk about risk every day, the risk of into a car accident on a particular highway. In public health, if 5 out of 100 unvaccinated children in a school get measles, then the risk of measles will be 5%, 5 out of 100. That you're looking at the probability. What is the probability that those who are not having the disease will get it? So I get those who have the disease, divide by those at risk. So many times the risk is a measure of incidence, as we talked about. You get number of new cases divided by number of people at risk. You can say that the risk in this population is 20%. The risk in this population was 50%. It means that the probability in the other population, out of 100, 20 will become sick. That is, you're looking at risk. It is always ranges from 0 to 1, or 0% to 100%. So it cannot be greater than 100, simply because the new cases cannot exceed the people at risk. The maximum is if all people who were exposed became sick, then you see that the risk is 100%. Relative risk, we are comparing. As you said, relative risk you can be considering in a cohort study. You measure the risk in those who are exposed, then the risk in the unexposed. Then you want to compare what is the relative risk. So it is a ratio of the risk of a disease in the exposed to the unexposed. If you look at this graph, there's what we call the attributable risk. If I look at the people who are unexposed and I compare with the exposed, the difference between the two is the risk attributed to the exposure. It means that this increment, like here you're seeing this increment, it is because of the exposure. Because those who were unexposed, they reached this level. It becomes the baseline. Now this additional, it becomes the attributable risk. So that is the simple calculation. Relative risk, get risk in the exposed divided by the risk in the unexposed. If the relative risk is 1, meaning there is no association. Why? If the risk among the exposed and the risk in the unexposed is the same, meaning being exposed or not exposed changes nothing. There is no, like what you are looking at, there is no association between the two. But if it is greater than 1, it means there is a higher risk among those who are exposed. That is what we call a positive association. That when the exposure is high, the risk increases. But if the relative risk is calculated and is less than 1, it means this exposure is protective. Why? For this fraction to be less, it means that denominator is greater than the numerator. So if the risk in those who are not exposed is higher than the risk in those who are exposed, it means the exposure has protected, like being exposed reduced the rate of the disease. So meaning the exposure is protective, or is protective. As we said earlier, risk is only measured in cohort and randomized controlled trials, because that is when you are following up a population perspective and you are recording objective data. Odds they are ratio of probability. Odds is not a probability but a ratio of a probability that an event occurs to the probability that it does not occur. So you think of it in gambling, they usually use odds. The odds of winning a game might be 1 to 4. That means for every 1 win, there are 4 losses. Like you got the probability of winning, you divide it by the probability of losing, then you get the odds. In public health, if the risk of developing a disease is 5%, the odds of the disease, I get the risk divided by 1 minus. So the calculation is here, 1 minus the risk. Why? He said that when you're calculating odds, I get the probability that the event will happen divided by the probability that it will not happen. So if I'm having a probability, of course the probability, if I sum up the probability that it will happen plus probability that it will not happen, just to give me 1. So probability of an event not happening is equal to 1 minus the probability that it will happen. That is why this formula, if I know 1, I just get risk divided by 1 minus the risk. So if they say the incidence in the population is 5%, meaning the risk is 0.05, probability of not happening will be 1 minus 0.05, then you divide and you get the odds ratio. Unlike the relative risk, odds ratio can go up to infinity. You can divide and get 100 or you get 0.00, like it is 0 to infinity. And it is commonly used in case control studies because you cannot measure the risk. So you use the odds. You compare the odds among those with the disease. You compare with the odds among those without the disease because you are comparing cases and controls. That is what we mean by odds ratio. Is the ratio of the odds of exposure among cases to the odds of exposure among controls. So even when odds is a ratio, odds ratio is a ratio of ratios in brief, and we use it for comparing. We use it for comparing cases. Like I've used this glass to show cases and the controls. So just as relative risks compares risks, the odds ratio compares the odds of exposure between the cases to the odds of exposure between the controls. When we were measuring risk in cohort studies, we get the risk of developing the disease among the exposed, because in a cohort we begin with the exposed. So we get risks in exposed divided by risks in unexposed. But odds ratio, we get the odds in the cases divided by the odds in the controls. So the calculations, they vary. So this is an illustration. And if I collected data, the exposure is to the left, the disease are these vertical columns. Meaning in this column, these are people with a disease. In this column, these are people without the disease. So if I use the case control study, when I'm measuring odds, I'm going to measure the odds of exposure among the cases, those with the disease. Meaning I will get A, the odds. Yeah. Remember, odds we are dividing in probabilities. We are dividing probabilities. So I get A divided by the total, divided by C divided by the total. Because we said odds, we are dividing probabilities of not happening divided by probability of happening divided by probability of not happening. So if I'm in this column, the odds of exposure, I get the probability of becoming sick when you are exposed. That is A divided by the total, which has been illustrated here. Then I divide by the probability of not have been exposed. That is C out of the total. So that this ratio of these two probabilities gives me the odds of exposure among the cases. Then I go to the controls. I get the odds of exposure, that is B. I get those who were exposed, that is B, out of the total of those without the disease, divided by D out of the total. This is another odds. So when I'm getting odds ratio, after I'm getting these two values, I'm going to get this value up, the odds among the cases, divided by the odds among the controls. So this is just one odd and this is another odd. Then you compare. This is what has been summarized here. So you realize that after dividing, these sums will cancel out. This A plus C, when I divide these two probabilities, they cancel out. So in brief, you remain with A over C divided by B over D out of this complex calculation. Then after dividing, you get this common calculation, that AD out of BC, but it came from the other complex thing. The interpretation for odds ratio and relative risk, the interpretation for 1 is the same. If the odds ratio is 1, what does it mean? That the odds of exposure among the cases is the same as the odds of exposure among the controls. So there is no association between the exposure and the effect you are looking at. If there was some association, the odds ratio wouldn't have been 1, meaning the odds cannot be the same among the cases and controls if there is an association. Either one odd will be less than the other or the other will be greater. So if the odds ratio is 1, no association. If the odds ratio is greater than 1, it means that the exposure is associated with increased odds. Meaning the more the people are exposed, the higher the odds of the disease. If the odds ratio is less than 1, it means the exposure is associated with decreased odds. So this is mainly used in case control studies. As I said earlier, we only use it in cohort studies if the case that is being studied is a rare case. So that means that the disease has a high latency period or it has a very low prevalence. So what is assumed is that the odds ratio, the calculation of odds ratio will be approximately the same as that of relative risk. That is when it can be used in cohort. Dynamics of disease transmission. Dynamics, you're looking at how disease spreads from one host to another and what are the factors that influence the transmission. Of course, these are necessary parts of public health. Understanding disease transmission is understanding how a fire spreads. For example, if you're looking at fire, how you need fuel, you need oxygen, and oxygen supports burning, you need heat. So for a disease, it's about the pathogen. How will it move from one host to another? Who it can infect? If you think of a common cold, if you're looking at a common cold spreading through an office, so you ask yourselves, who got the cold first? What did they get? What will be the condition that the common cold? How did it spread? When? Where? You're getting it. Is it because of sneezing? Is it because of touching surfaces? How was the disease spreading? So these are the dynamics we mean by dynamics of disease transmission. In disease transmission, there's what we call a chain of infection. Chain of infection includes the agent, which in public health is the cause. Might be a virus or bacteria. You need to note that mainly in dynamics of disease transmission, we are talking about infectious diseases. What we call a reservoir is where the agent lives. If a disease is spreading from one person directly to another, then the sick person is the reservoir where the agent lives. It can be in the animals, it can be in the soil or water. So if for this disease to spread, it has to spread from the reservoir and then it enters into the host. So in cases of where the reservoir is a human being, is what you call the port of exit. How is the disease, this pathogen, going to leave one person so that it is going to spread to another? So there has to be a port of exit from the reservoir. So it can be saliva, maybe someone coughing, or or maybe through food, sharing spoons, whereby the pathogen is going to exit, or through feces, then the feces maybe enter into a water body or blood. That is what we call port of exit, how the pathogen leaves the reservoir. Then the mode of transmission, is it by a vector? Is it by direct contact or touching surfaces? The port of entry, there you are looking at the next host. It might be the respiratory tract. Have they just breathed it in? Has it gone through the skin? Was it through food? So we are seeing a chain of infection from the one host to another, or from the reservoir to a host. And lastly, the host has to be susceptible, because not everyone who gets the pathogen will fall sick. Means there must be attributes of this host that predisposes them to get ill, maybe being malnourished, maybe the genetics and the immunological factors, maybe low immunity. That's what we are looking at in chain of infection. Breaking the chain of infection is key to preventing disease. It is like breaking a physical chain. Okay. So for malaria, the agent is a plasmodium parasite. That is the agent. The reservoir is an infected human. Then was the malaria. The port of exit is through the bloodstream, because the mosquito will come and bite the skin. So through the blood which this mosquito has sucked, it will be the port of exit from this reservoir. Then there must be a mode of transmission. So this mosquito bite, the mosquito has to transmit the pathogen. Then after transmitting it, for it to reach the host, there must be a port of entry. So now it will use the human skin. The mosquito will go and bite, or it inject into the next person. Then the host must be susceptible for them to fall sick. That is a summary. And this one summarizes it. It can be body to body, that is direct transmission. It can be airborne. It can be sexual, that is through sexual intercourse. It can be vertical transmission, like from a mother to a newborn baby. It can be vector borne, like we have seen in the case of malaria. Fecal oral, someone defecates maybe through water, the water is used for domestic use and it enters into another host. So all those are examples of modes of transmission. When you're looking at the dynamics of this transmission, there's what you call herd immunity, HERD. And in this concept, it says that when enough people are immune, maybe through vaccination, or maybe they were exposed early and they got that secondary immunity, that if enough people are immune, the spread slows down or even stops, protecting those who are not immune. Meaning those who have not been vaccinated, they receive herd immunity if the biggest population has been vaccinated. So in this case, the herd immunity is like a shield. We're looking at, if you look at this in red, very few people have not been vaccinated. It is like a shield for the whole community. If enough people are vaccinated against measles, for example, this measles virus can't easily find new susceptible hosts to infect. So this will protect these vulnerable individuals who cannot be vaccinated, maybe like the infants, or you talk of those who have low immune systems, because the chain of transmission is broken. In brief, for someone to spread a disease from one person to another, the host must be susceptible. So if most people have been immunized, then the chain of transmission is broken or is slow, because most of the people in the population are not susceptible. Incubation period is also a concept under disease transmission, which we call the time between exposure and the onset of symptoms. It is important for quarantine and intervention timing. Just like you see this illustration I've used of a chick coming out of an egg. Incubation period, signs and symptoms have not appeared. Someone got the coronavirus, but then after 2 weeks, that is when you are seeing signs and symptoms of COVID-19. Meaning now these 14 days will have been the incubation period. So the incubation period is like a silent phase. It's like a silent phase. You are infected, but you are not showing symptoms, yet you might be contagious, meaning you can spread to someone else. That is why they come up with quarantine measures. They restrict some people, because if you are in the incubation period, you assume that you are not sick, yet you are spreading the disease to others. In the study of in epidemiological studies, is what you call an epidemic curve, which is a graph showing the number of new cases over time. Meaning, if you're doing it monthly, that's how many cases you record, how many cases, new cases you go on recording. So meaning the curve will have the incidence. It is like a curve which you have made out of the incidence measurements. Then you plot it usually as a line graph. So sometimes they use bar graphs. That is what we are calling an epidemic curve, and is usually made during cases of epidemics. As cases are being reported timely, curves are plotted to see it can show this epidemic curve is a representation of the attack rate. Because if the new cases are increasing, probably it shows that the interventions that are being used are not slowing down its rate. But if the new cases go on decreasing, meaning probably the interventions are reducing the of the disease. So these are measures of the speed of disease transmission. Again, attack rate, epidemic curve. It gives you that illustration of how disease is spreading. And lastly, there are three terms: endemic, epidemic, and pandemic. So what we call an endemic disease, that is constant presence or usual prevalence of a disease within a given geographic area, meaning it is usual occurrence. It may not necessarily be low, but even if the cases are high, but they are usual, like they are constant, the prevalence is constant in that given geographic area. Like the way malaria is endemic for sub-Saharan Africa. So that's what is being rated illustrated by this curve. There is that level which is known or which is expected. That is when we say that this disease is endemic for this area. So in brief, endemic means a disease is consistently present in a region. It is like a background noise that you're used to that no longer alarms you, like the case of malaria. So for the cases of endemic, it is expected and there is a known stable level. So it is not necessarily low, but it is predictable. Meaning even if it is varying, it is between predictable ranges and is often maintained by continuous transmission. So it is present in the area. It is not does not reduce, does not increase highly. So you find the people are curing while new ones are getting sick. The ones are curing, new ones are getting sick. So the curve remains slightly flat. Epidemics, occurrence of disease cases in a population clearly in excess of normal expectancy. In endemic, we say it is within expected ranges, but it will be called an epidemic if it rapidly goes beyond the normal expectancy. For example, if Uganda normally sees 100 cases of cholera per month, but suddenly there are like 500 cases in a single district, that one becomes an epidemic because it is beyond the usual prevalence. And it's usually a localized surge. Like you talk of Ebola, so that Ebola is in what, northwestern Uganda or in this region. Those are epidemics. Sudden increase. It might be in a school, it might be in a region or a country. So usually epidemics are localized. It may involve new or re-emerging infections. The infection may be an outbreak or a re-emerging infection like cholera. And we have talked of an outbreak of cholera in a refugee settlement can be classified as an epidemic. Lastly, pandemic, which is in brief you can call a worldwide epidemic. An epidemic occurring worldwide or over a very wide area, crossing international boundaries. So it may be a pandemic over maybe two continents. It has crossed from one continent to another. It has crossed international boundaries in many countries. Then it is tagged as a pandemic. So the most recent is COVID-19. Key points: it has to be global in scale, affects multiple continents or populations, and requires international coordination to manage. Thank you so much for watching.